Hello everyone and welcome to our Simulate in Healthcare webinar. This month we are joined by Tracey England from ABCi, who is going to be giving us some examples of simulation modelling in ABUHB. Tracey will give you more of an introduction to herself, so without further ado I'll hand over to you, Tracey.
Thanks very much, Tom. As Tom's just mentioned, I'm going to just go over some examples of simulation modelling that we've carried out in the health board. ABUHB stands for Aneurin Bevan University Health Board. We're one of 7 health boards in Wales. So it's a very different setup to the health boards and trusts within England and Scotland. So hopefully you'll find this interesting, and if there's any questions at the end, then let me know. So what I'd like to just go over is to introduce the ABCi team, because we're quite unusual. We're actually a mixture of improvement modelers and also sort of program and project managers as well. So it's quite a mixture of people. I'll give a brief introduction into who I am and what my specialties are, and then just go through 3 case studies which hopefully will give you an illustration of the types of modelling that we've been doing lately. So this is the ABCi team. There are 19 of us. I'm not quite sure if we're all in the photo. It's quite difficult to get us all in one place at one time. It's headed up by John Bolton, who some of you might know. He's quite a keen Simulate user. The modelling team are labelled, so they're actually 4 postdoc mathematicians, and we're headed up by Isabella, who has expertise in Excel modelling and also simulation. Doris is more system dynamics, Daniel is mathematical programming, and then I typically do simulation and forecasting. So in terms of what ABCi does, our remit really is to provide capability, innovation and delivery into the health board. So for the mathematical modelling team, of which there are 4 of us, we've developed a talk programme for people within the health board so they can use operational techniques, one of which is Simulate. So we've run 1 cohort last year, and we're starting a cohort this year. Last year we actually had 3 Simulate projects that came off the back of the modelling programme, and we had 2 in demand and capacity and 1 in reconfiguration of services. So who am I? I'm one of the mathematical modellers. I've been there in ABCi now for 4 years. I tend to do discrete event simulation, so I use quite a lot of Simulate, and I helped Ed Osler and Fiona with the bed pack evaluation last year, and I also do a lot of forecasting as well, so I'm trying to get that into the health board at the moment. So the first case study I'd like to introduce is actually a patient flow simulation model. It was set in the Trauma and Orthopaedics department of the Royal Gwent Hospital in Newport. So as a bit of background, it's a very busy unit. The Royal Gwent is in the centre of Newport. The Trauma and Orthopaedic Clinic runs typically 80 fracture clinics in a 4-week rota, has 24 consultants, and it runs 207 elective clinics. That's typically carpal tunnel syndrome, hands and kind of shoulders and spine injuries, whereas the fracture clinic are more your broken arms and legs if you've had an accident. So what the directorate manager wanted us to have a look at was whether the configuration of rooms in the clinic spaces could be altered. At the time, there were 3 clinic spaces, and they wanted to change the configuration of the rooms in clinics 1 and 2. The clinicians were quite against the idea because they thought it would reduce the flow of patients through the clinics. So they wanted to actually have a look to see if we could evaluate the before and after scenario. So the way we set about the project was we actually obtained the physical layout of the clinics for a floor plan. We then shadowed numerous clinics over a 3-4 month period. We then built the simulation model and checked it with the clinicians involved, and then we ran some baseline models and scenarios and then presented the results. This is the floor plan of the clinic, and if I use the laser pen, I should be able to actually show you. This was the entrance routine that patients would come in. They'd go to reception, they'd take a seat in the waiting room, and then they'd be called either to one of these clinics or one of these clinic rooms. And typically they're just curtained off cubicle areas. So what the actual department wanted to know was whether these 5 cubicle rooms here could be reduced to 4 slightly larger ones with doors on, and again here whether these could be changed. So it seemed a reasonable project, and we thought, oh, it won't take too long, everything will be fine. And then we conducted quite a few sort of shadowing exercises and expert opinion, and we found out the clinic was a bit more like this. So quite a lot more going on. Rooms weren't actually being used as we thought they were being used and had multiple purposes. So at that point, we decided we were actually going to do a patient flow model and actually track the patients through the clinics and then see what would happen if we reduced the number of rooms from 5 to 4. Typically, we split each of the patient's pathways into distinct steps. So you can see here we've got the nurse calling a patient, and then the patient moving into the clinic area, and then the actual patient going into the cubicle and then waiting for the doctor to come whilst the nurse actually puts the notes in the cubicle pockets. With the shadowing exercises, we were able to sort of time each of these elements individually and then build up the distributions behind the icons. In terms of actually seeing the consultant, we timed how long each patient was in with the consultant. As the cubicles had curtains, we sat on the outside and then just timed when patients or doctors went in or out. So we didn't actually interfere with any of the consulting. We also looked at physiotherapists and special wounds nurses because they use the cubicles as well as the consultants. So we wanted to make sure we were getting a full view of how the clinics were running. So the full model, which looks quite complicated, we have kind of an initial streamlined pathway that we would hope each of the patients would go through that's along here. But quite often what could happen is either at this point or this point, a patient might get directed up to the plaster room or the x-ray room and then have to circle back round and then come back in again. So there's quite a lot going on. We also looked at the special wounds nurses separately and the physios, and then all the resources are here. So we had quite a lot of information going in on the model, but it was, we hoped, quite realistic and would convince the clinicians that we'd actually had a thorough look as to the problem. We actually conducted the shadowing exercises between October and January, and we also talked to quite a lot of the consultants, nurses and physios to see how they actually conducted each of their consultations with the patients. What we found with running the baseline and the actual scenario is that if we did reduce the rooms, it did slow up the clinics considerably, especially when we had consultants and physios using the same clinic space. We noticed that if the clinics were prepared quite well ahead, then actually it became more streamlined and the turnaround time in the clinic was much shorter. So we were able to sort of put in a few kind of behavioural aspects that actually would improve the throughput and the patient experience rather than having to spend a lot of money altering the clinic space. We found out that shadowing was really important. Although we weren't actually in the consultations, we could see what was going on, and quite often just being there meant that the clinicians would tell us extra bits of information, which was really nice. So that's the first case study. The second one is more of a national programme and relates to 111 coming into Wales. At the time of the study, Wales didn't have 111 like England. It was a little bit wary about actually rolling out the programme, so it's decided to actually do a step-by-step health board by health board. So this project was actually right at the start with the first health board, or actually just ahead of the first health board going live, and actually analysing all their data and producing some simulation models for it. So the first health board, which conducted the Pathfinder project, was ABMU, which is actually the health board around Swansea. And what we were asked to do was to look at the call volume data for GB out of hours and NHS Direct Wales. Because the idea was that the call volumes from each of those two services would combine when they come through to 111. So the two current systems run quite differently. NHS Direct Wales runs 24 hours a day, whereas the GP out of hours only runs in the evenings and then at weekends. And they have different types of staff looking after each service. So we wanted to actually look at the call volumes and then look at the staffing rotas as well when we combine the two services. In order to do that, we had the data from both NHS Direct Wales for the whole of Wales and then the out of hours call volumes for each of the 7 health boards. So in total, for a year's worth of data, we were looking at about 800,000 call volume, and we divided it initially into the two systems so we could produce simulation models for each, and then we developed a combined model which we ran as a baseline, and then we could alter different sections of it to see what staff did what and what effect it would have. So this is the initial simulation model screenshot that we had for NHS Direct Wales. Each of the icons relate to the staff that handled the call at that time, and then the icons along the bottom are the outcomes. So it may be a call to a GP was needed afterwards, or the patient was referred to A&E, or they could look after themselves at home. So there are quite a lot of different options with NHS Direct. We had a similar model that we built for the GP out of hours service, and each of those was separate for each health board. We were then lucky enough to have an MSc student over the summer who actually combined both the NHS Direct model and GP out of hours into one easy to use model. So this side are all the different call volume types that come in from NHS Direct and GP out of hours. These are the processes that the calls go through depending on what type of call they are. This was a checking mechanism to make sure we hadn't lost any calls, and then we have the staffing resources along the bottom, so we could see how utilised each of those staffing resources were under the scenarios. What was really nice about being able to do this is it allowed the 111 team the option of trying out different workforce options and costing them ahead of actually putting the figures into Welsh Government and getting the agreement to go ahead on the Pathfinder project, and then the actual 111 service in ABMU and now in subsequent health boards. So just being able to develop a model and visualise it was really, really useful to them. The final case study is quite a new one and relates to actually 2 of the modelling fellows that we've trained in our silver modelling course, and they're looking at demand and capacity. So in particular, the health board have struggled really to understand demand on outpatient clinics, particularly as they've tended to focus on activity rather than the referral demand that comes in. So by building this simulation model, the modelling fellows have been able to look at the referral patterns, and they're using it to actually look at new and follow-up appointments and the staff needed, and also capture the variation from week to week. So the actual model came off the back of one that's been developed in the health board for ophthalmology. The modelling fellows are still really in the pilot stages. They're concentrating on one subspecialty. They've actually developed the discrete model, and it's using daily or weekly data, depending on what the service wants to find out. And in terms of the weekly model, they've also incorporated a forecasting model so that they can then forecast as well as using a simulation to show what's going to happen to demand in the future. So this is just a screenshot of one of the subspecialties they've been working on. essentially a booking will come in and that will generate a new appointment for, in this subspecialty, arthroplasty. And then depending on whether the patient attends their appointment or cancels it or doesn't attend or they're discharged, they may go up into a follow-up pool, and there's different sort of outcomes for that as well. So quite often in outpatients, a patient may cycle through the follow-up loop several times. So this is why it's useful to have simulation, because one thing that hasn't been captured in the past is how many follow-up appointments a patient might need off the back of a new appointment, and this is allowing the service to do that as well. So the modelling fellows have found it is allowing them to understand the referral demand from each subspecialty. They can see the variation, and in the plot below you can actually see the forecasting model that they've produced. At the moment, over a 3-year period, it's out by about 6 referrals on about 36,000 data points. So it's doing really well, though it doesn't look as if it's matching exactly here. It's actually doing really, really well, so they're pleased. And then just to sort of pull some thoughts together, I think we found that Simulate's been really useful for looking at very large data sets and building models off the back of those. We've also found it very useful for when we've conducted small shadowing exercises, and then we can build a model that reflects what we're seeing there. The visualization for clinicians and managers has been really useful, because they can see what's happening in their clinics in a model, and then they're more likely to believe the results. And we've done quite a mixture of projects, so high-level models and ones that are looking at patient flow. In the future, well, in the next few sort of months, we're actually looking at a new hospital build, and we're hoping to use Simulate for part of that. And we're also looking at a full cancer pathway for lung cancer. So that's essentially what we've got planned, and we're using Simulate for as well. So it's been an incredibly useful tool for us in the health board. And that's it really. That's what we've been up to of late in AB UHB modelling. It's not all that we do, but discrete event simulation does help a huge amount. Thank you very much.
Thank you very much, Tracey. A really good presentation showing, various simulations there, all really interesting. I've just got a couple of questions for you.
Okay.
So it seems like you're lucky enough to work in a very talented team with a combination of lots of different analytical skill sets. What sort of goes into a decision criteria for you to decide to use Simulate over potentially other tools? What kind of things do you look for in a project that would lead you towards Simulate?
Sometimes it's a case of data quality. Sometimes it's the user specification, in that they want the visual side of things so they can present to other people, and they want the what if scenarios. Occasionally it may be kind of just how complicated something is. So whether you can break it down into smaller parts, it varies really. So the piece of work we're thinking about doing for the new hospital build, that's an area we're really trying to work out which is going to be the best option on the modelling techniques. And we came up with quite a few, and we still haven't decided which one we're going to go for yet.
Okay, great. And one other question, I can see that you'd use simulation well to answer the main questions that you had in a lot of your projects, but you also kind of touched upon some additional benefits that came out of running a project with simulation. That, for example, the need to maybe shadow clinicians and things like that. I mean, how would you always run a project to make sure that you're getting those kind of additional benefits? Would you recommend something like shadowing all the time when it's appropriate, even if you have data, for example?
I think it's very useful to try and get at least 1 or 2 clinicians on board right at the start. And quite often they will say, come and have a look at the clinic. So even if you're not formally shadowing, it's good to go and have those discussions, because quite often the data might tell you one thing, or you think it's telling you one thing, but when you actually see it in action, it's very different.
Yeah.
So it's always worth doing that shadowing side of things, because just things come up that might explain why there's a blip in the data or why something just seems unusual. For instance, when we were doing the patient flow model for the trauma clinic, they actually had a nasty road traffic accident on that day, and that department would have been closed for outpatients and then would have accepted patients from the road traffic accident. So that would have been a very different set of data than usual.
Yeah.
So if we hadn't been shadowing, we wouldn't have known that.
Yeah, I think that I've seen as well. It's always good to be able to capture information that's going to help you feed all the inputs into the model and all the variation that we know can happen in real life to get that valid representation. So yeah, excellent. Thanks again to you, Tracey, for presenting. Thanks everybody for listening.